Our next speaker is Dr. YeouChing Su, who is a pediatric endocrinologist with Northwell. And her bio is with the announcement with all the other bios. So just in the interest of time, I'm not going to say much more, but she's a very well-established and well-known pediatric endocrinologist. And she will talk about something we don't, as adult, perhaps care providers, we don't think about very much, and that is the care of transgender youths.
Okay. Hi, y'all. Thank you so much for having me. Very good to see everyone. And of course, I'm going to be talking about some of the things that are very dear to us. I hope I know how to use this. How do I advance the slides? Okay, great. So as Dr. Mitra has already spoken well, that we do know that transgender patients in general are a very marginalized group with very high rates of depression, anxiety, suicidal ideation, and completed suicide. And it is quite a grim picture. There is significant healthcare disparity, as he already discussed as well. And for transgender children and adolescents, many of us know that there is a very high rate of bullying and a very high rate of suicide attempts, sadly. And there are some factors that we know well that are associated with improved mental health and quality of life for everyone. Psychosocial support, having family, and that could be related or unrelated, having really family that they can go to, engagement with psychotherapy, social transitioning, gender affirming care, and gender reassignment. These are all things that are helping with their overall wellness. So, and this is just a very, not a whole list, but as you can see very briefly that there are many medical associations and mental health associations, and of course that includes the World Professional Association for Transgender Health that are supporting very supportive of hormonal treatment for our patients. There are many guidelines, as Dr. Mitra has already said, that include standards of care from the WPATH. It's still getting very heavily edited, so it's slightly dated, but it is still a good basis. And the Endocrine Society guidelines, which is also co-sponsored by many organizations. Everyone can read here, including Pediatric Endocrine Society and WPATH that has came out as well. And these guidelines, they help us guide our care of our patients to make sure they are as healthy as they can be and as well as they can be. So, and they do tell us about the mental health professional for our patients. We do want to make sure that they have good mental health professionals who are adept at working with our patients. It's important that they have competence and ability to make distinction between gender dysphoria, gender incongruence, and conditions that have similar features, and their training in diagnosing mental health conditions, and able to assess how well they understand the risks and benefits of these treatments, make sure their mental health and social conditions are well supported so that they don't impact the gender affirming hormone therapy. And of course, a lot of what we do is also just make sure our patients are safe in general. And of course, we make sure that we all regularly attend relevant professional meetings, and that's why we are all here. In children, it's important that they also understand child and adolescents' developmental psychology and psychopathology, as children are different than just young adults, as we all know. And it's important that in the ones who do work with child and adolescents, that they also work with, it's not working now, they also know the criteria for puberty blocking and gender affirming treatment in the adolescents. Next slide. So with prepubertal children, it's a special group that I just want to mention briefly. And so Gender variance and gender dysphoria, gender incongruence during childhood does seem to not inevitably continue. I do understand this is an area of big debate, but there are studies that shows maybe upwards of 75-80% of the patients, children may not continue. And if anyone's ever worked with children, they do just overall, even when their gender identity is very firm, they may say certain things like, oh, I feel like being a princess when they are birth assigned male, and that's perfectly fine. I always work with patients and family to know that certain comments you support them, love them well, and allow them to be themselves as much as possible. And so because persistence into adulthood in terms of gender incongruence and dysphoria seems to be much higher in adolescents, prepubertal children treatment is not recommended. Again, that does not mean that you shouldn't be supporting the children and allow them to express themselves. So the guidelines do specifically recommend against puberty blocking and gender affirming hormone treatment. Again, that doesn't mean that they don't support that they should have a good safe environment, and also support them should they have any sort of gender variance. We do make sure that they're supported. There is nothing to treat if you have prepubertal children, because the blockers do have their own side effects, and you wouldn't want to use them without actually a child being pubertal. And there is definitely data that gender dysphoria that worsens with the onset of puberty it is a strong indicator that they have persistence. Okay. And one other reason not to treat these patients is it's very hard to predict when puberty actually may commence. So in terms of pubertal suppression therapy, there are very good reasons, though, that we do them. Pubertal changes that are of their birth assigned gender can seriously interfere with their psychosocial functioning overall. The physical outcomes is improved when this is started early, before the end of puberty. It's definitely been shown that it has improved a lot of our patients' psychological functioning, and it is fully reversible. Their natal puberty, the puberty of their birth assigned gender, will restart after treatment is stopped. And this really does allow a lot of them to explore their gender dysphoria, their gender incongruence, and prolong your diagnostic phase. And it also facilitates transition for our patients to not have to have physical changes that makes it harder for them to live as themselves. And this is recommended in the guidelines to be the first treatment. I think partly there are some patients, of course, you'll have to see your patients who are well into puberty. This might not be something that is needed. So with all our patients, before they start the treatment, we do discuss with them so that they have a very clear expectation concerning the effects of treatment. They will hold puberty for certain, but we have to make sure they do understand that this does not cause any masculinization or feminization. And we also have to make sure that we do counsel them regarding options of fertility preservation before starting hormone treatment. I tell all my patients that it is not that we want you to have children, but this is something where there have actually been various surveys of patients who have transitioned. They realize that if they had known this could have been an option for them back then, they would have considered it. So, different options that we have. So pubertal suppression, we have gonadotropin releasing hormone agonist. That is the one that is recommended and works the best. There are many different forms. Leuprolide acetate initially years and years ago came as daily injections. We're lucky that it is now monthly depot or every 3 months depot that we use. Not too long ago, there's a every 6 month depot that is quite a big shot that we haven't really used yet. Mostly in Europe, we have gonadotropin acetate, and triptorelin is also been found in the market. There is a 6 month formulation as well. And then lastly, there is an implant that can be used, a hystrelin implant. There is one formulation for precocious puberty and one for prostate cancer or benign prostatic atrophy, hypertrophy. So those things both are, the dosage is slightly different, but efficacy have been found to be very good. Some of the patients actually use the adult formulation as needed. Lastly, there is a nasal spray. I should mention that the treatments that we discussed, technically they are not FDA approved, but as you know, we have a lot of treatments that we use in children that are not technically FDA approved, but have been shown to have very good response and very helpful for our patients. The nasal spray, I will just say that is not very efficacious, so generally only a center or a few that could get it easily use them. Okay, so it is important to know still what are some of the potential side effects. So I always speak with them. Largely what we know are from experience from patients who are on treatment for early puberty, but it also for hormone responsive cancer or infertility that they use it for. So I always warn my parents and patients that they may read about this side effect or that side effect. A lot of them may be reported from these patients who are quite ill. So generally it is very safe. So there is a caveat to the reversible and intact fertility. When it is started before the end of puberty, there are many times that fertility simply will not be possible based on the technology we have currently. Things are always changing, but we do want to make sure that they are aware of this. So next, sterile abscess, for some reason I didn't see it in the guidelines, but it is a very significant inflammation to the injection area that can be seen with the depot formulation. Even the implant has had it here and there, but it's extremely rare. But if there is inflammation does occur, we do have to make sure that the treatment is stopped and other forms of treatment. There has been weight gain that's described. I really have only seen this in my patients who have precocious puberty, because all of a sudden they are having their growth spurt and eating a lot and they're not growing anymore. And there's also some decrease in lean body mass percentage. They can have some mood swings, generally not too bad, and after a while they're stabilized. And then there are also potential for hot flashes, and they could get menses or spotting with the first free treatment. So perhaps the main thing that will be prolonged is there is concern of bone mineral density in the long run, and Dr. Poresky is, their center is having a study looking at bone mineral density. For the most part, they seem to catch up pretty much to normal ranges. Okay. So I'm going to go over the next slide, even though it's very important. As we discussed, it really does suppress sperm and ovarian stimulation, and the young children, unfortunately, will not be able to make be fertile when it started early enough, and it's very important we have family involved to discuss that, knowing that this could be a concern. And the next slide, I'll also skip over a little bit for the anti-androgens quickly, because Dr. Dr. Liu will be discussing this more. Overall, the anti-androgens unfortunately do not work well by themselves, so we generally do go for blockers. And the next part is we do have some other options for some of our trans males or non-binary patients who do not want to have periods. It's not specifically noted in the guidelines, but it's certainly a practical consideration. Of course, even in cisgender female who do not want to have periods, there are different options. I always review with all my patients that not to think of this as a medication for female or male, but this is a medication that some people take. You can use combined estrogen and progesterone pill that can keep the menses at bay. We can't use only estrogen, that tend to not work well. Only progesterone pill can lower the spotting, but not so great. I personally don't love Depo-Provera because of the irregular periods, could be pretty significant. Intrauterine device is another option. I do find that to be more preferable to the Depo-Provera. It does cause the menses to lighten, and some patients can repeat complete amenorrhea. Progestins I mentioned before sometimes can have a irregular spotting. Okay, so you have your patients. Depending on when you meet them, they may be started on a hormone blocking treatment, and then at some point they meet the criteria for cross-sex hormone treatment. And again, mental health professional, different providers that they work continue to confirm there is persistence of gender dysphoria, and any coexisting problem is addressed. They said they do want to make sure the adolescents have sufficient mental capacity to have a good understanding of the risks or benefits of treatment, and most of them will be 16 years of age or so when they have good enough of a maturation and understanding. You want to make sure they understand the benefits and risks and informed consent to this practically irreversible treatment. Some people call our hormone treatment as partially irreversible because it could be reversed by surgery. But again, we have to discuss with them. Unfortunately, there is, after starting the treatment going forward, there is definitely a much higher, even if they're mature enough, there is potential for loss of fertility. Okay, so, and we, of course, these endocrinologists also confirm that patients are well and that there are no medical contraindication for hormone treatment, and what are things that we can do to alleviate risk should our patient have any risk for cross-sex hormone treatment. So the goals, which we all know fairly well, to masculinize or feminize the body, to improve their quality of life, to improve their self-esteem, and definitely well shown to decrease gender dysphoria. Lots of data showing it decreases anxiety. For a period of time, there weren't as much research showing decrease in depression, probably because of a lot of the stigma that is still associated with gender variance, but that definitely more and more studies have shown that it's improving. And lastly, very importantly, to decrease our patients from having risky behavior that would cause them otherwise to be not as healthy as they used it. And just quick caveats, and I will let Dr. Luke go. Some things is that generally I do try to keep my patients on hormone suppressive treatment until gonadectomy if they want to. Depending on their hormones, it may be enough to suppress their hormones and we might wean it off. And we do have to work with our patients that it's sometimes they could be potentially too tall or too short to their liking in the future. So with a hormone treatment, with a blocking, we do make sure we monitor the height and growth very consistently in addition to everything else we monitor. Thank you so much for your time. Okay, I will Dr. Lee.